Now, myasthenia gravis is very, very easy to remember if you know this diagram. So this diagram is of your neuromuscular junction. So as we know, the neuromuscular junction, so this is your motor end plate, or you can think this is your muscle. And this is your nerve end plate. And this is your neuromuscular junction, typically. And as we know, once the action potential travels down the nerves, what happens is these are your acetylcholine vesicles. And from these acetylcholine vesicles, you see these acetylcholine coming out and attaching themselves to the acetylcholine receptors on the muscle end plate. And you get your nerve action potential or muscle action potential. So muscles contraction all happens because of this. What happens typically in myasthenia gravis is, just see at the microscopic level, what happens is antibodies get formed against these acetylcholine receptors. So most of the cases of myasthenia gravis, antibodies get formed against the acetylcholine receptors. So these receptors which are there on the muscle end plate, so antibodies get formed. And that is why, because of these antibodies, these receptors start getting damaged. And that is why, because there are less receptors, acetylcholine has nobody to act. Okay. And that is why the patient has complaints of muscle weakness, because no acetylcholine coming on the acetylcholine receptors. And that is why weakness. What happens is, around some cases, there is no antibodies against the acetylcholine receptors. What happens is, there are antibodies known as anti-musk antibodies. So what are these anti-musk antibodies? These anti-musk antibodies are anti-muscle specific kinase. That is, certain antibodies which directly affect your muscles. So anti-musk antibodies are present, wherein your muscle fibers, some antibodies get formed against them. So around 80% patients who are acetylcholine receptor antibodies negative, they can have these directly anti-musk antibodies positive. Okay. And there are certain other antibodies also, if you want to remember. So what happens is, again, this is a neuromuscular junction. This is your motor end plate. This is your nerve end plate. So there are certain antibodies against certain components of these parts. So there can be anti-agrin antibodies. And there is one more component at the muscle level. These are known as your anti-LRP4 antibodies. So these things have to be marked up, because anti-agrin, you can remember, it is at the upper end, and anti-LRP is at the motor end plate. So these are the other two antibodies. Apart from that, there are certain other named antibodies, anti-netrin and anti-Casper. So these are all newer antibodies which are there, but they might ask you all antibodies which are found in myasthenia gravis except. So you should know, typically most commonly is anti-acetylcholine receptor antibody, most common antibody. Apart from that, if that is not there, patient can have anti-musk antibody. If that is not there, anti-agrin antibody, anti-LRP4 antibody, and other two antibodies are anti-netrin and anti-Casper. Okay, so far so good. Coming to the clinical features, very, very, very important is weakness and fatigability of muscles. So how do they talk about this fatigability? There is usually diurnal variation of the fatigability. What does diurnal variation mean? The patient will say he's okay initially in the morning and all, and once he starts using the muscles over the period of time or towards the end of the day, he starts feeling muscle weakness. What this means is, once he starts using up his muscles, he starts developing weakness and fatigability. Why? Because as your acetylcholine receptors start getting fatigue, or acetylcholine receptor antibodies are there, so whatever acetylcholine is formed, the acetylcholine acts on these acetylcholine receptors, and the patient has a muscle potential. But what happens is towards the end of the day, what happens is less and less secretion occurs and less, more and more acetylcholine receptor starts getting deregulated. And that is why at the end of the day, typically these patients say as they start using up their muscles, they have weakness and fatigability. Repeated use increases weakness. Repeated use increases the weakness of the patients. What is myasthenic crisis? So the definition of myasthenic crisis, they might ask you, myasthenic crisis means patient has developed respiratory muscle weakness. And that is why the patient needs ventilatory support. So patient is on ventilator basically because he's developed respiratory muscle weakness. Now, very, very typical to know is the distribution of weakness. So typically this weakness, the patient starts with the extraocular muscles. So as we know from our MBBS, there's a typical example, which they give the celebrity having myasthenia gravis is Amitabh Bachchan. And just remember, extraocular muscles are the first muscles to get involved, wherein the patient starts having symptoms of ptosis. What is ptosis? This drooping of the eyelid. I'll show you an image of ptosis. And after that, patient starts having features of dysarthria. Why? Because your tongue muscles, your palate muscles, they start having weakness. And that is why the patient's voice, as towards the end of the day, he starts using more, he talks more and more, he's feeling fatigued while talking. So after a period of time, usually it starts with ptosis, then they have dysarthria, they can have bulbar weakness. And 85% of the cases, after 1 or 2 years, they have something known as generalized myasthenia gravis. What is generalized myasthenia gravis? Where along with your extraocular muscles, your bulbar muscles, your tongue muscles, palate muscles, the upper and the lower limb muscles also. They start getting fatigued. So that is why that is known as generalized myasthenia gravis. Okay, that is known as generalized myasthenia gravis. 85% of the cases over the period of time, they develop the generalized myasthenia gravis. Now, very, very important entity to remember is what is ocular myasthenia gravis. So as I told you, extraocular muscles start getting involved first. So if the weakness remains restricted only to your extraocular muscles for a period of 2 years or more, wherein the patient has only features of ptosis and features because of your extraocular muscle involvement, that is known as ocular myasthenia gravis. No other muscles are involved. Okay, that is ocular myasthenia gravis, wherein only extraocular muscles are involved for 2 years or more. Okay. So we read about ocular myasthenia gravis, we read about generalized myasthenia gravis, wherein 85% of the cases after developing ptosis, bulbar weakness, tongue muscle weakness, because of that patient has dysarthria, palatal weakness. And after that, they develop weakness of upper limbs and lower limbs, and the weakness becomes generalized. That is a generalized myasthenia gravis. I told you what is ocular myasthenia gravis. We discussed the clinical features, whereas repeated use of the muscles, diurnal variation of weakness is that towards the end of the day, more and more weakness happens. I told you about the antibodies. Typically, most commonly, acetylcholine receptor antibody. Apart from that, anti-MuSK antibody, anti-agrin antibodies, anti-LRP4 antibodies, and the newer antibodies, anti-netrin and anti-Casper antibodies. I told you about the clinical features. Coming to the investigations, now they might ask you what is the bedside test for myasthenia gravis. So this is the bedside test, beautiful test. As you can see, this patient is having ptosis, and once he applies ice to that part of the eyelid, his ptosis has resolved. So when do you consider this test as positive? So we usually apply ice to the eyelids of the patient for around 2 minutes. And if the eye opens for more than 2 millimeters, the ptosis resolves by more than 2 millimeters, this test is considered positive. And we can diagnose this patient is having myasthenia gravis. Now, why does ice help in myasthenia gravis, this test? Because what happens is the ice, it starts inhibiting your acetylcholinesterase. So remember, let me take you again to this nerve action potential, this NMJ junction, we know the acetylcholine which comes out, it is broken down by an enzyme known as acetylcholinesterase. So once acetylcholinesterase breaks down this enzyme, less acetylcholine is available for acting on the acetylcholine receptor. So now ICE is going to break down this, or ICE is going to inhibit acetylcholinesterase. That is why more and more acetylcholine is available for acting on the acetylcholine receptors. And that is why in ICE pack test, the basis is once we apply ICE, acetylcholinesterase is inhibited a little, and that is why acetylcholine can act more on the acetylcholine. Whatever acetylcholine receptors are present, the minute quantity. It is not that all the acetylcholine receptors have antibodies. Small fraction of acetylcholine receptors are still present in the patient, and that is why that is the basis of this test. So ICE pack test, if they ask you, this is a bedside test, and remember the rule of 2 minutes. Usually we apply this ICE, and more than 2 millimeter, the eye should open. So this, see this was initially early, then we applied ICE, and later the ptosis resolved a little bit. This is the ICE pack test. Now there is another test known as electrodiagnostic test. What we do is we rapidly stimulate the nerve, rapid nerve stimulation. As we know, repeated use of the muscle is going to cause what? It is going to increase the patient's weakness. So the same thing happens once we rapidly stimulate the nerve. So initially, if this was the amplitude of the action potential, if you start stimulating rapidly, what happens in these patients is the amplitude starts falling. So reduction in amplitude by more than 10% on repeated nerve stimulation, it indicates it is a positive test. So you have to remember this value, more than 10% reduction in amplitude. So this was the initial amplitude, the amplitude reduced to this part. So this is another test. There is one more test known as edrophonium test. This is known as anticholinesterase test. The same thing by which ICE was acting. So what edrophonium does is, it is a drug which is going to inhibit your anticholinesterase. And that is why you're, again, same thing, your acetylcholine has a free path to act on your acetylcholine receptors because anticholinesterase is inhibited. Now remember one thing, edrophonium test is a very risky test. It has to be done in ICU settings only with cardiac monitoring, because these patients can crash once you give edrophonium. And where this test is reserved, only when clinically you think the patient is having myasthenia, but your test, your final test, that is your antibody test, wherein we do a lot of antibodies. Typically we do which antibodies clinically? In our scenarios, we do anti-acetylcholine receptor antibodies and we do anti-MuSK antibodies. We check for these antibodies. So once all the antibodies are negative, along with that your rapid nerve stimulation test is also negative. So now we are in a dilemma where we think clinically this patient has myasthenia, but these investigations, they are not yielding any fruit. So only in those settings this test is reserved. Very, very rarely these tests is done now, because the patient can have a lot of side effects. The patient can have autonomic features, patient can have nausea, vomiting, patient can have salivation, all those things. Patient can drown in his secretions and all these things. That is why we don't do this test anymore. A lot of times we don't do this test. This test is only reserved where there is a dilemma because investigations are not yielding any fruit. Basis is same, edrophonium, also known as tensilon test. Same name, tensilon is the brand name for edrophonium. So it is going to inhibit your anticholinesterase, and that is why your acetylcholine has a free path to act on your acetylcholine receptors. And that is why what happens is the ptosis or the other weakness which was there in the patient, that is going to get resolved once we give edrophonium. How much edrophonium do we give? Initially we give 2 mg edrophonium. If there is no response, we check for side effects. If there are no side effects, we can go ahead and we give 8 mg. Okay, so you have to remember edrophonium test as well. And there is one more syndrome which you have to remember along with myasthenia, and that is Lambert-Eaton myasthenia syndrome. Now over here, let me bring forth a small thing. Now Myasthenia gravis, which is there, typically it is associated with thymoma. Around 70 to 80% of the cases are associated with thymoma, wherein once you find out that the patient is having myasthenia gravis, what we do is we check for thymoma and we operate these patients. Or vis-a-vis, if you find out on your X-ray or any other CT, thorax or something we have done, and we find out that the patient is having thymoma, we always look out if the patient is having myasthenia gravis. It is that common, the association. And once we operate this thymoma, what happens is the patient's need for drugs for myasthenia gravis, around 50% of the cases, you don't need to treat them, because once thymoma is removed, they have a common, they say antibodies are produced because of this thymoma in myasthenia gravis against the acetylcholine receptors, and that is that the patient gets relieved once you do an operation for thymoma. Okay. Now this Lambert-Eaton myasthenic syndrome, why is it important? Because a strong association is present with small cell lung cancer. So these two associations you have to remember: myasthenia gravis with thymoma and Lambert-Eaton with small cell lung cancer. But in the same thing, if the patient you think has a small cell lung cancer on biopsy, we look out if he has Lambert-Eaton. And if you find out Lambert-Eaton, you look if the patient is having small cell lung cancer. Now, very, very important thing to know is what happens at the molecular level. As we know, in myasthenia gravis, antibodies were getting formed against the acetylcholine receptors. Whereas in this Lambert-Eaton syndrome, what happens is antibodies are formed against these calcium channels, also known as your VQ-gated calcium channels. And remember, very important thing, these calcium channels are important for release of acetylcholine. These calcium channels, because calcium goes in, then because of that only what happens was acetylcholine comes out. So because antibodies are formed against these calcium channels, there is no release of acetylcholine, and that is why the patient has weakness. See, muscle pathology, if you see, this was normal, wherein the calcium channels were okay. Calcium was going inside the nerve end plate, and because of that, acetylcholine was getting released. But what happens in Lambert-Eaton is because antibodies, these are the antibodies, because antibodies are formed against these channels, no calcium going in. That is why no acetylcholine coming out. So calcium is basically an important thing for release of acetylcholine from the vesicles. So Lambert-Eaton, remember, it is a syndrome against the VQ-gated calcium channels. Okay, and let me bring out another two concepts here. Lambert-Eaton is typically a triad of proximal muscle involvement, typically of the lower limbs. Patient usually has areflexia. Remember, in myasthenia gravis, there is no areflexia. So usually proximal muscle weakness of the lower limbs mainly, and areflexia, and obviously presynaptic terminal. There is antibodies. So myasthenia gravis postsynaptic. This is a synapse, as we know. So myasthenia gravis, there is postsynaptic receptor antibodies, whereas in Lambert-Eaton, there is presynaptic because the calcium channels are present presynaptically. So it is proximal muscle involvement, mainly lower limb muscles, and there is areflexia. 100% of the times, if they want to grill you, they will grill you on SCLC mainly, if you know SCLC, and if you know the concept that there is areflexia in myasthenia. Whereas vis-a-vis in myasthenia gravis, there is no areflexia. In myasthenia gravis, there is only muscle weakness, but reflexes are normal. But Lambert-Eaton, the reflexes are also gone. Okay. Coming to the treatment for myasthenia. So once your diagnosis is confirmed, with the help of your clinical diagnosis along with your labs, that is rapid nerve stimulation we do, that is clinical, plus we opt for rapid nerve stimulation, and most specific is we do find out the antibodies, typically anti-acetylcholine receptor and anti-MuSK, because other antibodies, typically you will find these two antibodies to be there, anti-acetylcholine receptor and anti-MuSK antibodies. So once you confirm this, what you will give? Acetylcholine esterase inhibitors, obviously, because once you give acetylcholine esterase inhibitors, now which are these drugs? Pyridostigmine and neostigmine. Pyridostigmine we usually give to our patients, and the dose is 60 milligrams per day, 4 times per day. Okay, so 60 mg we give for 4 times. and we can increase it up to 120 mg QID. So what are these drugs? These are nothing but anticholinesterase inhibitors. I told you why anticholinesterase inhibitors we have to give, because they will help, because they will not break down your acetylcholine, and whatever acetylcholine is there, or whatever acetylcholine is going to act on your acetylcholine receptors, and the patient's weakness will improve. And along with that, usually we go for thymectomy. I told you the relation. Once you do thymectomy, around 50% of the patients don't need any treatment. We see if the patient has improved or not. If the patient is improved, we continue with these drugs. Usually these patients need these drugs for a long time. If the patient does not improve with these drugs, we usually have to give them prednisolone or azathioprine. If still they do not improve, we have to give other drugs like mycophenolate mofetil or rituximab. And they still don't improve, we go for cyclosporine or tacrolimus. So just remember 2-3 things here. Usually start with anti-acetylcholinesterase inhibitors as the drugs. Along with that, we usually go for thymectomy. If there is no effect, then we go for other drugs like prednisolone, mycophenolate mofetil, tacrolimus, cyclosporine, all these drugs. Okay, so this is in short about the treatment for generalized myasthenia gravis. But what if the patient has come in crisis? As I told you, what is crisis? Crisis is the patient's respiratory muscles are also involved now, and that is why he needs ventilatory support. So in these cases, what we have to, the role of IVIG and plasma exchange is there, plasmapheresis. So it is only, you have to mark the answer only is myasthenia crisis, where we admit these patients in ICU, put them on ventilator, and we give IVIG or plasma exchange. And if that does not help, we usually go for steroids as well. Remember one thing, once the patient is in crisis, we have to stop the other drugs. That is acetylcholinesterase inhibitors we have to stop for these patients. Okay.